I have a talk in one of the sessions, the Chronic Malignancies Working Party, speaking about how new agents, new drugs that we have in multiple myeloma, how this will affect the procedure of the stem cell transplantation, not probably now, but probably in the upcoming years, as the end of the talk title is Beyond 2016. In fact, there are many novel mechanisms of action that are being used currently in multiple myeloma, and some of them are old ones in which we have a second generation of agents such as proteasome inhibitors or immunomodulatory agents. But what is very important is that in the last year we have the approval of 4 new drugs in multiple myeloma, and even 3 of them with novel mechanisms of action, that was the acetylase inhibitors and a couple of monoclonal antibodies, anti-CD38 and anti-SLAMF7. So I think this is very important because for the first time we have novel agents with novel mechanisms to treat our patients. Moreover, in the near future, we will have several other agents coming that are being investigated, other monoclonal antibodies, particularly focusing on immunotherapy, and some other targeted agents that target specific mechanisms of the tumor cells that probably will be in the clinical scenario near. One important question that has been raised in the last years is if, with the appearance of all these novel drugs, bone marrow transplantation should remain standard of care for young multiple myeloma patients. A recent study published, presented at last ASH meeting by the French group showed that definitely patients that received an autologous transplantation did better, had a better outcome, better survival than those patients that did not have this autologous transplantation in the first line treatment but at relapse. So I think this demonstrates that autologous stem cell transplantation have to remain a standard of care for these young myeloma patients. But as we have many other drugs, myeloma patients do not achieve the cure, many of them, so myeloma is still considered an incurable disease. I think it's important to find or to search for novel strategies to improve the outcome and the prognosis of even these young myeloma patients. And in this regard comes all these novel strategies, novel agents that can be positioned in different places in the procedure of the autologous transplantation to try to improve them. As I will present in my talk, there are some novel alkylators that could replace melphalan. Melphalan has been the standard of care for this transplantation, and there are novel alkylators with novel mechanisms, some, I would say, more fashion alkylators that could replace more effective and less toxic. Also, we have all these second generations of the currently available agents that could induce deeper responses. With less toxicity profile. We have carfilzomib, ixazomib, novel proteasome inhibitors, which in the induction phase before the transplant could have also deeper responses and go in better situation to the procedure, to the transplantation procedure. And also I think we have some good data on some, although much of this data is preliminary because most of these agents have been tested in the relapsed situation. As they are novel, first you have to test them in the relapsed situation, in relapsed patients. But now we are moving more and more to the first line scenario. And in this regard, some of these monoclonal antibodies, for instance, or other drugs such as the acetylase inhibitors that have demonstrated activity in the relapsed situation, they could be moved to for instance, to the use in maintenance setting after transplant to try to keep the disease under control for a long periods of time. And finally, I think I would also mention that some of these agents could be incorporated also as a 4th drug partner in the induction therapy. Up to now, we knew that 4 drug combinations were not better than 3 drug combinations in the induction. That was with the classical drugs. Now we know that the addition of a novel drug as a fourth drug, combined, for instance, with VTD or VRD, bortezomib, lenalidomide, dexamethasone, plus a novel drug such as ponovinostat, the acetylase inhibitor, or a monoclonal antibody, which I think would be a revolution in the treatment of myeloma, the monoclonal antibodies, this could enhance more the responses and the efficacy of the bone marrow transplantation. That's a very difficult question to answer. In fact, because it depends on which is our purpose for these patients. I think I'm quite optimistic in this regard, and I think our goal should be to try to cure myeloma patients, most importantly or mainly those young patients. And I think so we have to optimize very much the treatment of these young myeloma patients, candidates to autologous stem cell transplantation. Probably in this regard, a very good combination with a proteasome inhibitor, a second generation proteasome inhibitor, second generation IMiD, steroids, and probably the addition of a novel agent such as daratumumab, a monoclonal antibody, should be a goal with the best possible induction, followed by an optimized conditioning regime for the transplant, probably a consolidation with some different agents, and a maintenance phase, trying to keep with the immune system, trying to stimulate the immune system to keep the tumor clone under control. So with the final aim probably of curing the disease in the first line.